52-year-old patient sat across from Dr. Amara in the quiet intensity of the oncology suite. While his primary uveal melanoma had been managed with local ocular therapy years prior, recent surveillance revealed a sobering shift: systemic progression. Dr. Amara adjusted the digital display, where a high-resolution MRI of Soren's liver showed the telltale hypervascular lesions of metastatic disease. The clinical challenge was clear. Traditional checkpoints often failed in this cold, immune environment, and a more targeted, innovative approach was now necessary to bridge the gap between the tumor and the immune system. At the molecular level, the uveal melanoma cells within Soren's body were not entirely invisible. They expressed GP100, a lineage-specific antigen, which was processed and presented on the cell surface by HLA-A's 201 molecules. However, the surrounding T-cells lacked the natural receptors to recognize these specific peptide MHC complexes, allowing the tumor to evade detection. The cold nature of these tumors meant that even with the antigen present, the immune system remained a distant bystander, unable to initiate a cytotoxic response without a specialized molecular key. Dr. Amara reviewed the laboratory results that would determine the next steps in Soren's care. To utilize Tebentafusp, a bispecific GP100 peptide-directed T-cell receptor, TCR fusion protein, Soren had to be HLA-A's 201 positive. She pointed to the laboratory report on her tablet, which confirmed his status. This diagnostic marker was the essential prerequisite for the therapy, ensuring that the Tebentafusp molecule could accurately dock onto the melanoma cells while simultaneously engaging the patient's own immune effector cells. The intervention began with the introduction of Tebentafusp, an IMTAC, immune-mobilizing monoclonal TCR against cancer. This bispecific molecule served as a physical and functional bridge. One end of the protein, a high-affinity TCR, bound specifically to the GP100 HLA complex on the melanoma cell. The other end, an anti-CD3 scFv, captured a cytotoxic T-cell. By bypassing the need for natural TCR recognition, the bridge brought the T-cell into direct contact with the tumor, triggering the release of cytotoxic granules and initiating the redirected lysis of the malignant cell. Months later, the clinical impact of this T-cell redirection became evident. Soren's follow-up imaging showed a stabilization and reduction in the metastatic burden, reflecting the survival benefit demonstrated in landmark clinical trials. Dr. Amara noted that Tebentafusp represented a paradigm shift. It was the first systemic therapy to successfully recruit the immune system against metastatic uveal melanoma. For Soren, the bispecific bridge had transformed a cold tumor into a target, providing a path forward where few had existed before.